My professor has this quote which he uses a lot, that there are no safe anesthetic drugs, there are no safe anesthetic protocols, there are only safe anesthetists.
Hey there, and welcome to our channel, Your Veterinary Mentor with Dr. Sachi. Today's mentor, Dr. Sahil Mehta, has a working experience of more than 6 years. He is a trusted anesthetist who will make sure the patient is stable during any surgery. Dr. Sahil is currently working as an anesthetist at Speciality Vets. They have branches including the eye vet, the cancer vet, and the exotics vet. They offer residency programs for veterinary students and vets who choose to specialize in any of these fields. Today, let's learn about veterinary anesthesiology from Dr. Sahil. Anesthesia can be a very challenging subject,
Hmm.
and a lot of times it seems to be challenging more because we know the side effects that the drugs have. We have a few questions ready for you, which, as per our interaction with students, we have figured that these things seem to be a little difficult to understand.
Right.
What are the various anesthetics that are used in different practices, or the anesthetics that you have used, whether they're injectable, inhalant, local blocks, regional blocks? Can
Hmm.
you give us a description about these?
So we have lot of drugs available in India. Starting with sedatives, we have sorry, acethromycin, dexmedetomidine, xylazine, um, benzodiazepines like midazolam, diazepam, sedatives, sorry, induction agents, propofol, thiopentone, ketamine. Thiopentone is now majorly a euthanasia drug, but it is there are many others like neuromuscular blockers, atracurium, and reversal drugs, atipamezole, neostigmine. Many drugs which used to not be available for veterinary use in India are now available. Inhalants, sevoflurane, isoflurane. Most of the clinics use isoflurane, but sevoflurane is available as well. Halothane, more or less, nobody uses it now. Then local anesthetics, lidocaine, bupivacaine, are very commonly available for veterinary use in India.
So, you have also been using these drugs regularly in practice?
Yes, I have.
And as compared to what we learned in college,
Hmm.
what are the different advances that have happened in anesthesia or anesthetic management now?
So when I was studying in my undergrad, I knew a few drugs, triflupromazine, Sequil, the trade name, and thiopentone and ketamine was major part of anesthesia what I've seen.
And then
And then
xylazine.
yes, and xylazine, and then the patients were connected to gas machine with isoflurane. But in postgrad, I was I got to know about many different drugs and how to use them properly. Dexmedetomidine was something which was very new to me. Propofol, midazolam, diazepam. These drugs were used, but not very commonly and not on a routine basis. Then we have multimodal analgesic techniques where you don't use just one drug to take care of the pain. You use alpha 2 adrenoceptors to take care of your visceral pain. You use ketamine not as an anesthetic drug, but as a somatic analgesia for bones or muscle or skin. The It blocks the pain receptors which arise from these areas. Then we have regional blocks like ESP blocks, erector spinae plane block, which is the local anesthetic drug is injected in the paraspinal area, and it will desensitize all the muscles and the nerves which arise from the spine.
Hmm.
And it helps a lot with chronic pain, acute pain.
These kind of advances are usually learned after we leave college.
Yes.
In case there is a student who is interested in learning anesthesia better,
Hmm.
what are the basic things that or basic knowledge that that student should have in terms of the previous subjects that we learn, because anesthesia we usually learn in the last year
Right.
with surgery.
Hmm.
But what subjects of before should they know well so that they can learn anesthesia more easily?
So I would suggest first of all start with being a good diagnostician. You should perform physical exam in all the patients you come across. Physical exam includes auscultation, thorough examination of eyes, mucous membranes, dentition, starting from tip of the nose till the tail. Uh, Palpate the abdomen. Try to listen to abnormal heart sounds or lung sounds. It should be so thorough that the blood work what we do before the surgery, that should be your supportive evidence. uh, 80% of your decision should be made just based on your physical exam, that this patient is fit to undergo anesthesia and everything should be fine. People don't even touch, the doctors unfortunately don't even touch patients when they come for a pre-op exam. Directly blood sample is drawn, that is tested. If everything is fine, the surgery is scheduled for the next day or a week later, but that is not how it should be. No, physical exam is as important as the surgery. Once you know that you have a problem, then you treat that condition first, and then if it is an elective surgery, you can postpone the procedure. If it is not, then it depends on the condition what you face.
Biochemistry for the blood work that comes back to interpret it, or physiology so that you know the normal conditions to differentiate from abnormal. And any other subjects of our initial few years that they should know before learning
Physiology and pharmacology are very important because those were my minor subjects when I was doing my postgrad diploma, and it helps a lot to understand why are the blood results what you get are abnormal, and what can you do to correct the condition, or if the surgery has to be cancelled or postponed, then I would suggest stay focused on your physiology, pharmacology, and clinical medicine. These three subjects help a lot when you go for anesthesiology.
So these are the basics that they should know before they even think of anesthesia. In case we have to choose sedatives, anesthetics, or we have to come up with a protocol for any surgery, what are the basic criteria that anyone should consider for any animal or any surgery?
Majorly for small animal clinic practice, you will have dogs and cats to be scheduled for surgeries. So the age of the patient, what breed they belong to, if it is a brachycephalic dogs, what all general considerations you should keep in mind before selecting any sedatives or anesthetics. So many brachycephalics, they are contraindicated for aspromazine because it causes hypotension, vasodilation, and they can't tolerate that well. Then their airway needs to be secured once you anesthetize them, and they should be pre-oxygenated before undergoing general anesthesia, so they don't get hypoxemic. Then age wise, if it is a very young patient, then you can't use drugs which cause vasodilation or which causes bradycardia or something, or they should not be fasted for a very long time. For patients below 2 months of age, you ideally should not fast them at all. They have to keep their food and water intake as it is regularly done. Otherwise, they go hypoglycemic. For geriatric patients, there are few things which you should keep in mind, that a few of them might have arthritis, for which you can't properly keep their legs straight, tight to the table. Otherwise, it will cause acute pain. Already, they are suffering from arthritis, and a few of them might start limping after the surgery. which is not very pleasant for clients to
Yeah.
explain later.
The difficult thing for us. Like these conditions that we decided based on a general surgery, what are the different drugs that we might need to choose if it is an orthopedic, a soft tissue, or an ophthalmic surgery? So there are three different, because soft tissue is more of visceral organs
Right.
that we are going to be dealing with. Orthopedic is all the joints and bones.
Right.
Ophthalmic is only localized to the eye. So in these surgeries, what is different when you're choosing the drug? What changes in these criteria?
So all three are different conditions where the duration of surgery differs immensely. Orthopedic surgeries might go on for say 2 hours to 4 hours, depending on what condition it is. Soft tissue surgery needs more of visceral pain management, and post-operative care is more extensive than an ophthalmic surgery. Eye surgeries are comparatively shorter in duration. For eye surgeries, the pain management is lesser than soft tissue and orthopedic conditions. For orthopedics, I prefer using CRIs of different painkillers put together, so the intraoperative and postoperative pain is managed. Uh, uh, then I prefer using gabapentin for postoperative care in orthopedic conditions, because the neuropathic pain is a lot after undergoing, say, an amputation where you get phantom pain. And for soft tissue surgeries, depending on the duration and what exactly the surgery is, if it is OVH for females, or exploratory laparotomy. So the duration of surgery is shorter for OVH. For exploratory laparotomy, you take a little longer time. And if there is something uh, complicated which you have, suppose there is a foreign body which you need to anastomose the intestines later. So the choice of drugs depends on what you have to deal with. So speak with your surgeons, thoroughly get an idea of what are the steps they would be performing, and opioids are good choice for pain management. NSAIDs, if the condition allows for it. NSAIDs or a low dose of meloxicam would also do, because you do need anti-inflammatory drugs to deal with such conditions, especially when they are invasive and extensive, like an anastomosis. Dexmedetomidine is a very good analgesic when you deal with abdominal pain. And for post-operative management, I would go for trypsin, chymotrypsin, because it helps with managing the seroma, which happens after the surgery because of the incision which is taken. Buprenorphine is a long-acting opioid which helps with pain management after surgery.
This in all three, or specifically soft tissue, orthopedic, or
This
ophthalmic?
can be used for all three, because even for orthopedic surgeries, you do get fluid built up after at the site of surgery. For ophthalmic surgeries, not really.
So when we have a procedure, like you're working with these specialties, when we have a procedure for uh, an eye, maybe a tumor in the eye, and then you have a procedure which is invasive or a large tumor within the abdomen for the cancer vet. Then in these two procedures, what is the difference in the anesthetic protocol that you will choose?
So, if you're asking about what drugs I would choose, is
No, not the drug as such, but what is the criteria that changes in these two patients that will change the protocol that you're going to, whatever protocol that you will choose?
okay. So for tumor in the eye, the attachments are quite narrow. If even if it even if it is attached to the entire eye, it's not as big as a tumor in the abdomen. Say it's a kidney tumor or a tumor on the spleen, where the entire organ has to be removed from the body. Uh, in that, the major difference is in pain management. See, anesthesia Basically comprises of three main aspects. One is a reversible unconsciousness, one is analgesia, which is pain management, and one is muscle relaxation. Reversible unconsciousness, because obviously we want our patients to wake up after the surgery. Muscle relaxation is more necessary for a soft tissue surgery, which is in the abdomen, not so much for the eye. There are ocular muscles as well, but the relaxation which the surgeon expects is more in the abdominal procedure, not in the ocular surgery. And the third one remains is pain management. A tumor attached to the eye is not as painful as a tumor in the abdomen, which is where the continuous supply of a painkiller, which can be done through constant rate infusion (CRI), or it can be done with a local regional infiltration of a local anesthetic.
How does all this differ in exotics?
Exotics are it's a completely different world. The choice of drugs, basically the management of the OR, which has to be done in an exotic compared to a small animal patient, is very different. These patients, they need a heat supplement. Their body temperature is higher than the small animals, and it can't come down to room temperature, or how in small animals it drops down to say 2 or 3 degree Fahrenheit. These patients, they can't tolerate that drop of temperature.
So how does that affect the anesthetics that you choose in them?
Because a drop in temperature is going to slow down metabolism, and it will slow down excretion of the anesthetics what we use, and that will cause delay in recovery, or prolonged sedation, which is not expected from our side, and that is not something which we have prepared the client for. Pre-operative communication with the client is very important as well.
As an anesthetist, how many times have you had to go and probably, even if it's a scheduled procedure, but when you have done the physical exam for the patient once it's in front of you, how many times have you said, I'm not going to do this because you're found something that may have been missed by the surgeon or by the physician or anyone else? Okay.
Fortunately, I've worked with good surgeons, so that is something rare. But a couple of times I have asked the surgeon if I've taken their opinion as well. I think this is a problem, and we should maybe postpone the procedure, or manage this condition first and then schedule it again. So that fortunately has happened before I've sedated the patient.
Before. During a
Yes,
physical.
during a pre-op physical check, and very rarely I have not had any issues.
So you've been lucky.
Very lucky.
Okay, so like we discussed that age is also a criteria, or different physiological conditions that the animal may have are criteria for deciding on anesthetics. I have a few questions in terms of situations where we have to do the procedure and there's a condition to it, and what kind of drugs would be safe for that condition.
Okay.
So say if it's a senior dog with a cardiac condition and has to undergo a procedure,
Right.
then what would be the safer drugs available that we can use?
My professor has this quote which he uses a lot, that there are no safe anesthetic drugs, there are no safe anesthetic protocols, there are only safe anesthetists.
Yeah.
But yes, the choice of drugs depend on the patient, what you are presented with. If it is an emergency surgery which the patient has to undergo, then you can't be choosy that this is the condition, and I don't think the patient is fit for anesthesia. But obviously the surgery has to be done. There are opioids which are quite safe when used at a proper dose for cardiac patients. benzodiazepines, midazolam or diazepam are safer to use, and they don't have a major impact on the heart. Drugs like propofol are short acting, and it has bronchodilatory effect which helps with the breathing as well. At low doses, it is safe to use for such patients which uh, gets anesthetized faster, and you can quickly secure the airway. Place IV cannula beforehand. That helps with the circulation through your fluids. You need to have your emergency drugs in place. Your drugs like atropine, epinephrine, doxapram, these are must-have drugs for a practice, uh, which takes care of the blood pressure, heart rate, CRI of dobutamine for dogs, dopamine for cats, should be kept in place if you have such patients. What I prefer, or I would like others also to have this thing in their practice where you have checklist of necessary things which you must have for a particular case. If it is a cardiac patient, you have to secure an IV line for them. IV cannula must be placed. Um, then what all drugs you need, those have to be made sure that they are on the table in hands reach for them. Syringes, needles have to be ready. You can't waste time opening a syringe when adverse effect occurs. Um, Oxygenate the patients, pre-oxygenate the patients at least for 10-15 minutes before they are anesthetized. That helps.
Any drug that you would completely say no to for a cardiac case?
I would say acefromazine, because it causes hypotension, because it is a vasodilatory drug, and it will also reduce your heart rate. At low doses, it can be used depending on what exact condition you have. You can have mitral valve insufficiency, or dilated cardiomyopathy, or hypertrophic cardiomyopathy. So, with MVI, it's safe to use it at a lower dose, but maybe not for DCM because the cardiac walls are thinner.
And then, if I go to another case of, say, a diabetic cat,
Hmm.
what kind of drugs would you use for them? Because we can have quite, when it comes to a cat, we already have limited use of drugs.
uh, okay, so for diabetic patients, especially a cat, the absolute no drug would be alpha 2 adrenoceptor, xylazine or dexmedetomidine, because it blocks the secretion of insulin from your pancreas, and the glucose level keeps rising. Uh, instead of what drugs you can use, I can tell you what drugs you should not use at all.
Yeah.
And then the remaining are the safe ones. Uh, Also, ketamine I would prefer not to use because it causes a short-term release of catecholamines, epinephrine, norepinephrine, which will again affect your glucose levels. Safe drugs, if you want to use, you can use opioids, midazolam, and propofol is a good choice for diabetic cats.
An anesthetic that would be safe in case of kidney disease, or anesthetics that should not be used in kidney disease?
Again, acefromazine is a strict no, because once hypotension sets in, it will reduce blood flow to the kidney. Kidney gets about 25% of the blood which is pumped from the heart for filtration. Once renal blood flow is less, your glomerular filtration rate goes down, and that causes acute kidney injury. So I would avoid acefromazine, I would avoid alpha 2 adrenoceptors, and ketamine as well, because ketamine, once it gets metabolized, the active metabolite is norketamine, which is nephrotoxic. So using opioids, opioids are safe for any patient at a proper dose. You have butorphanol, buprenorphine, fentanyl, which are readily available for veterinary use. Benzodiazepines are very safe for, say, liver insufficiency or kidney insufficiency. And propofol is a good drug choice because it is short acting. It does not put a lot of load on liver and kidney to get metabolized and excreted.
So all of these drugs, we always have to remember the pharmacology before we decide on anything.
Yes, it's better if you know about the pharmacokinetics, how the drug affects the body, and from where all it passes through, where it is metabolized. So you know that this drug I can't use for, say, a renal insufficiency patient. This drug I can use for hepatic insufficiency. This drug is safe if the patient has pleural effusion. So
Pharmacology is a very important subject.
very important subject. I did not pay attention. I just wanted to pass my exams in pharmacology, physiology, but then later when I was studying anesthesia, I understood the fortunately they were my minor subjects, so I got time to study that. But otherwise, it's a problem if you take it for granted.
In a condition of pyometra, which has been a closed pyometra, which has come to you now as an emergency, now that you have to operate on this dog,
right,
or a cat for that matter. At that point, obviously, since it's an emergency, you don't have time to be picky about what you want and don't want or when you want to do the surgery. But then at this point, what is the drug that you will still say no to?
Okay. So close pyometra, many patients get septicemic because the bacteria does not get out of the body and it gets absorbed in the circulation. Many patients are not as active, rather active. I would say they are dull because of septicemia and pyrexia they undergo in this condition. So you can use your sedatives at a lower dose, and that is enough for you to prepare the patient for the surgery. You get enough time to shave, place an IV cannula. As muscle relaxants, you can use benzodiazepines, and ketamine is a decent choice for pyometra surgery. I would completely avoid propofol because it has egg lecithin as its preservative, which gives bacteria a substrate to multiply. So propofol is something I try to avoid unless I have a choice. Otherwise, at a low dose, propofol will also do.
There's this chill protocol that a lot of people don't know about, which we figure much later.
Yes.
Since these are also part of anesthetic drugs only, I want to ask you, what is this chill protocol and when should it be used? And is it safe to be used in cats?
Chill protocol is essentially take a chill pill. It's a combination of drugs which are used to sedate patients. Rather sedate, I would say, to calm them down.
Just calm them down.
For patients who are apprehensive, who are fearful, anxious, aggressive. So you get in this protocol, it's gabapentin, aceflomazine injectable, which you can spurt in the mouth, and it gets absorbed through transmucosally. Melatonin. Okay, so with gabapentin, it's a mild sedative with good anxiolysis. Melatonin, it acts on your serotonin receptors, antagonizes the serotonin receptors, and it inhibits the reuptake of serotonin, which causes drowsiness, sleepiness. And Acethromycin is a good sedative. It is also behavior modifier, essentially anxiolysis. So a combination of this gives a synergistic effect of calming down and sedation, not complete sedation where the patient is knocked out, but just enough for us to
Be able to
be
approach it.
comfortable and the patient is compliant with that. It is safe to use in cats. Only drawback is and it's a personal thing, I don't trust clients with injectable
Yeah.
medications at home, even if it is a transmucosal or to be used as a syrup. But if something goes wrong while bringing the patient from home till the hospital, then it can be a little
Bad for us.
yes. But there are safer drugs like trazodone tablets are available, which can be used for cats. Gabapentin and trazodone is one combination which is used in the US and quite safe for cats as well.
You've tried these drugs personally. You've done the chill protocol for any dog?
Not so far, I haven't.
You haven't had to?
I didn't have to. More or less, gabapentin was enough for us to handle the patients, aggressive dogs or cats. But no, I haven't used trazodone. I have not prescribed or dispensed acethromycin like that to any patient. Or melatonin is one thing we don't. I'm not aware of any veterinary product of melatonin, but the human tablet which we get, it has xylitol in it, which
Oh,
is toxic
kindness.
for dogs and cats. So, it is for humans. It's a sweetener used as a flavor, but for dogs and cats, it is toxic.
In when we talk about the chill protocol, any condition is irrespective of the behavior of the animal, any condition that you would avoid using the protocol if you ever had
For
to?
hepatic patients, I would use it at a lower dose, or I would just prescribe gabapentin, which is safer for this.
So throughout pharmacology, when we were studying, we always
Mm.
read a drug and we were very impressed by the drug and how what good effects it has.
Mm.
The side effects were there, which we knew we could always manage.
Mm.
And the end would always say contraindicated in cats. So in these anesthetics that we have
Mm.
available now, are there any drugs that you would be completely no when it comes to a cat, and why?
For an elective procedure in a healthy cat, there are no specific drugs I can think of which are contraindicated in cats. Opioids, sedatives, the drugs which we have now, more or less can be used for cats safely.
So unless there is a condition in the animal, in
Hmm.
specifically in that particular
That
animal,
works for
then
both dogs and
dogs.
cats.
But
So,
otherwise, there are no anesthetics that you would.
yes, lidocaine is one, which is contraindicated in cats. Or if you have to use it, absolutely have to use it, then you can use it at a very low dose. But that is something which causes neurological symptoms and can lead to a cat's death if not used properly. Lidocaine is something I would completely avoid in cats.
So, in case there is a surgery being done and there are some unexpected sudden side effects that animal starts showing
Mm.
of that whatever either one drug or a combination of drugs that we've used
Mm.
during the surgery happening, how would are you? Of course, now with experience, I'm
Mm.
sure you must be very calm.
Mm.
But in case, say, someone like me who's not used to doing anesthesia so often,
Mm.
or there's a new graduate or a veterinarian who's newly practicing,
Mm.
or one of your residents when you have other residents around, do you have any way that you all can calm yourselves down and then deal with the problem? Anything that you all
Mm.
do for it? Any kind of preparation before you go ahead with the surgery?
Mm. For a fresh graduate or someone with less experience, panicking is something which is going to happen. You can't really stop that. It takes time, it takes patience, and knowing, having knowledge about your drugs will save your time in not panicking, calming down, and to
Dealing
prepare
with
the
the
next
problem.
step of what you will be doing. If you have a reversal for the adverse side effect which has happened because of some particular drug you've used, uh, then reverse the drug quickly. That would be the first step to do. If there is something which you can't reverse or the reversal is not available in India, then
All the best.
then नहीं यार, all the best उससे try to bring the patient out of the anesthesia, turn off isoflurane or whatever is maintaining the patient under anesthesia, try to bring them out of that state. You can hydrate the patient so the drug gets excreted, eliminated faster. And there is a difference between an allergic reaction to a drug and hypersensitivity reaction. Allergic reaction happens when a patient is already exposed to that substance in the past multiple times, and then they develop allergic reactions. Hypersensitivity happens at the first exposure. You don't need to have previous exposure to that allergen or that substance. So you have to differentiate what exactly it is. I would, if it is an allergic reaction, say puffing of the face or eyes reddening or a proper allergic reaction, I would not hesitate using phenyramine, an antihistaminic Avil, the trade name, and a steroid to reverse this side effect. Doesn't matter what surgery it is, because saving that patient's life is more important. We can perform the surgery at any other point with a different set of drugs, but at the moment if patient बचेगा तो तुम surgery करोगे.
Exactly.
So that is something which we should keep in mind, that performing surgery is not important. Safety of this patient is more necessary at that point.
So knowing your drug will help a lot to
Exactly.
figure out
Again,
what
we come back to pharmacology.
Yeah. To know what kind of reaction when there
Yes,
is a
are
combination of
expected.
drugs used. If there is some reaction being shown, you should know which drug was the
Exactly.
problem, not
Or
not
that
be,
this is a side effect. This is not normal.
yeah, not be like, oh, and now I don't know which one is the problem, and now I don't know which
Exactly.
reversal to give.
Yes. So you should be ready. You should know what your drugs do. And if you're using a new drug, completely new to you, you can start with using. People ask me if, say, they get dexmedetomidine for the first time. They ask me, I want to use this, but I don't know how to use it or what dose should I use. I would suggest them to try it on a healthy patient first, not on a patient which has any pre-existing condition. And for an elective surgery, so if you learn driving a car, it is done with your father or mother, and it's near your house, be it a compound or in the lanes nearby. It's a controlled environment. You don't go on NH66 and सीधा भगाना नहीं होता गाड़ी. So if you have a new drug, you can try it on a healthy patient, elective surgery, and use it at a low dose, very low dose, and see if that does not work. Next time you can increase the dose, or if the patient gets sedated too deep, if the patient is too deeply sedated, then you can reduce the dose and try it next time with a different patient.
But your comfort with the anesthetic is very important.
Yes. So, if you have a new drug and don't use it at the label which is in the box, the dose for this is say 5 to 10 mg per kg. I would suggest try with maybe 1 or 2 mg per kg, because you will be combining a couple of drugs together. And the paper which says 5 to 10 mg per kg, that specifies the drug when it is used alone, not with a set of drugs which you, because the synergistic effect then
will make it more dangerous.
Yes.
Any challenging cases that you have dealt with, whether it was anesthesia or the procedure that was challenging? And what kind of preparation do you do before a surgery as an anesthetist?
Preparation wise, every morning I have this list of drugs with their doses written next to it. I prefer going through that because I have never by hearted any drug dose and I can't remember. I have a very bad memory. So I have all the set of drugs, butorphanol, the dose zero point 0.2 mg per kg or zero point 0.3 mg per kg. If it is a combination, then these are the drug doses. And I the previous day or when the surgery is scheduled, I know what surgery it is, what patient it is, the breed, age, entire history of the patient is with me. And if there is any special condition, I prefer reading about the drugs, about what all I can use and cannot use, and what all I should keep in mind. There is there is this Bible of Anesthesia, Lumb and Jones. Uska essential version is there, which concises the main parts of different conditions, say hepatic, renal, cardiac. So that book is quite concise, and I like to have a quick read through it, and that is how I keep myself prepared. And there also checklist. I have a mental checklist of things which I need. Simply placing one IV cannula. I So what all things you need. I also want other people to do this thing where be it the smallest step of placing an IV cannula. I need IV cannula, tapes, trimmer, and spirit, cotton, and maybe fluids to as a runner once the IV cannula. इतना basic चीज है, but some or the other person is going to miss out one thing out of that. Tape काट के निकाला ही नहीं है, so that becomes a hassle at the last moment. So similarly, if there is an emergency which occurs, then I should have these things with me at a stretcher, at a hands reach. I should not say कि यहाँ पर emergency है और मेरा emergency drug is in the OR. I don't have to run around and panic for that. So
this is the preparations that
that is my preparation. My most challenging surgery is also my favorite surgery. There is Tizer. This was during my college. Tizer was 2 months old when he was diagnosed with PRA and secondary megaesophagus, persistent right aortic arch, and we had to perform a thoracotomy to correct the condition. And that was the third intrathoracic surgery which was happening during my time in college. And my professor told me that you are going to perform surgery you are going to perform anesthesia for this one. In the first two procedures, I was an observer, and he had done anesthesia for the other two patients. And he told me that I will be supervising, but you have to lead this anesthesia. So I studied everything, like mega esophagus में क्या क्या complications आ सकते हैं, and PRA, how to correct it, what all steps are taken in the surgery. So I know that at this point the patient is going to feel the pain. Nociceptive stimulus हो सकता है at this point, and I almost knew more about the surgery than the surgeons did, because I wanted to do it properly, and it was a very major surgery for me at that point. So I prepared everything, and I think I had used nalbuphine and midazolam for sedation, and propofol to induce anesthesia. And there was CRI of, I think, lidocaine, ketamine, and no, I think it was just lidocaine and ketamine because quite a young patient. So the surgery lasted for 5.5 hours, and we had to use atracurium, neuromuscular blockade, so the surgeons can perform surgery with all the muscles, the thoracic muscles paralyzed. Otherwise, the manipulation
Would be
becomes
difficult.
difficult. So uh, I had to constantly manually ventilate the patient for about 2 hours till they could finish the procedure, and then they started suturing. Um, the surgery went well. He recovered well as well. After that, we had decided to keep him admitted for 3 days, and later the client will come pick him up. And the after day one of post-op, it started raining in Wayanad, and there was flood everywhere. Uh, and university declared that everyone has to go home. We will be closing down for 2 weeks. यूनिवर्सिटी में पानी बंद हो गया, इलेक्ट्रिसिटी बंद हो गया, and he was our inpatient, and he was the only patient we had during that time. And so I could not come back home because buses ka roads were shut. The airport was flooded, so there were no flights flying, and trains में reservation तो मिलना नहीं था at end moment. So I and my friend Dr. Rahul Rao, he has his own practice now in Bangalore. We decided to stay uh, at our places because we had rented places out. Then we stayed, and we told our professor that we will take care of him because he can't go anywhere. The client had come from some 80 kilometers away from the university. He could not come to pick him up because the roads were closed. So we decided, no, we'll keep him. And we could not take him home with us because he would get drenched in rain.
Yeah.
And even when we were on our scooter coming from, it was 500 meters away, my house to the university. Even if I'm wearing a windbreaker, pants, everything would get soaked by the time I reached the college. तो वैसे करके हमने उसको 7 days वी केप्ट हिम. इंडक्शन चालू रहता था हमारा थोड़ा टाइम, इलेक्ट्रिसिटी नहीं था, देयर वाज नो वाटर टू टेक अ बाथ. हमने फ्लड के पानी से ही बाल्टी भर के we would take bath and cook food in that same water for him. Fortunately, he had to be kept on rice and curd because of his mega esophagus. तो राइस बॉईल करके लेके जाते थे, उसको खिलाते थे, गिव हिम ऑल द मेडिसिन्स थ्राइस अ डे, एंड वी टुक केयर ऑफ हिम लाइक दैट, and he did very well.
So
We
all
were
of this was also the pain management and
yes,
thanks to him being with you.
exactly. So my favorite surgery, my favorite patient has been Tizer, and the last I know, he was doing very well. He's an adult now, so I'm very happy for him. We had such an experience. That was something. Yeah.
It was easy trying to deal with that as your first patient.
It he
Did
was.
that give you some confidence after?
It did. I had this fear of this being my first intrathoracic procedure. Sorry, independently, even if I was supervised, it was a controlled environment.
Yeah.
If something went wrong, my professor would be there for me. But yes, it does give you a lot of confidence when you have such supportive people around you. And if everything goes well, then confidence bahut aa jata hai.
No, like in this case, right from the preparation to his recovery, everything that you had to do and be on your toes and monitor him the whole time. That whole thing, you knew you had someone, but
Yes.
did the process of preparing also help with building your confidence?
Yes, once you do everything by yourself, you know what all challenges are there in to prepare a patient like that, or to take care of post-operative management. We did not have even assistants who stayed back. Everyone went home. It was just me and Dr. Rahul who did everything for him. So doing everything by yourself, by your own hands, that uh, that gives you a lot of confidence, and you know how to tell other people who, if in case you have some assistants with you, you know what to exactly to tell them and what they are supposed to do. It's not like कि हाँ ये कर देना और मैं कल आके देख लूंगा. Once you do everything by yourself, then you know how it is done exactly, or if you make any mistakes, you can correct them the next time and learn from those mistakes. So learning from your mistakes can give you more confidence than just doing it and praying कि कुछ गलत ना हो जाए.
Yes.
But don't intentionally make mistakes.
So, you've already answered this question, but like, are there any tricks for remembering anesthetics more easily? So that you already mentioned what you do is you have a chart in front of you which you look
Yes.
through every day so that it stays registered in your head. Every morning you get up with that in front of you. So since that is something that you're doing as your profession, as your career, as of being an anesthetist, it probably is a little easier for you to do it that way.
Exactly,
But as a
because I'm just
student,
doing this one
yeah,
thing
as
every
a
day.
student, what kind of tricks would you suggest for them to be able to remember certain, like the drug and the pharmacokinetics of the drug, the side effects that it can have, and the reversal doses? Obviously we have to remember it when we are in college, but for our exams,
Yeah.
but otherwise these things that are initially more important than the dose rate you can even look up later,
Yes.
but initial part of these drugs that they need to remember, how do you have any trick or a way of remembering these things?
There is no trick, but there are a handful drugs what we use in anesthesia. Barring the clinical medicine part of it, there are a handful drugs we use. And many of them are in groups. Say butorphanol, buprenorphine, fentanyl, morphine, hydromorphone, they are all opioids. Now, further, they are subclassified into mu agonist, opioid agonist, antagonist, and partial agonist. So all of them in the subclass have similar mechanism of action or pharmacokinetics. So instead of remembering these things for each drug, you can remember the class as a whole, and not get into individual drugs. That can happen later. Once you start specializing, you can remember. It's easier to remember each drug mechanism and pharmacodynamics, pharmacokinetics. Then the inhalant anesthetics, isoflurane, which is the major drug what we use, that has a different mechanism of action, but that's the only drug, the only agent which we use as an inhalant. So remembering that, and all the more or less many drugs have at the end a similar mechanism of action, like propofol and say uh, gabapentin. They kind of have similar pharmacokinetics. Like both of them will inhibit the GABA receptors, and then the drug works in the crossing the blood-brain barrier, and all those things are very similar. So if you remember one drug from each class, and then try to see if other drugs have similar mechanism of action, because at the end we have just one body, one brain. All drugs are going to act on your brain in some or the other way, be it different receptors, but end में तो तुम्हारा वही होने वाला है. It will get metabolized. Majority of drugs get metabolized in liver and excreted through kidney. तो उतना part तो तुम्हारा common है. You just have to remember what is different in this class or in this class.
In case there was anyone who was interested in becoming an anesthetist like you are, what kind of colleges or courses are available for someone like that?
The last I know, Kerala University offers postgrad diploma for a year, and Tanuvas University offers a degree program for 2 years. I'm not sure of the current status right now, but after me graduating from Kerala, I don't know if anyone opted for anesthesiology. That is very unfortunate.
Yeah.
Because
without anesthesia, there's no surgery.
Thing is that surgeons are taught anesthesia, but it is not their main focus.
Yeah.
They would obviously focus on surgery and the research and publishing a paper and then practicing as surgeons. But if you have someone to take care of this side of the patient, then it's safe for the patient as well, and it is
Lesser hassle for the surgeon also.
less hassle. Why would you focus on two different things? And once you have scrubbed in, you can't do half the things in anesthesia. You can't even rotate the isoflurane
Yeah.
knob.
You can't do anything in anesthesia.
Can't do anything in anesthesia except for if you have
Local.
local block, you can do that. But if there is an unfortunate incident that happens, then you have to again scrub in after handling that, and why to take that stress? uh, and one more thing is that it's very very fascinating, anesthesia as a field, and there are many things I've learned which I did not during my undergrad, which I should have paid attention, but now I'm learning them because I'm in anesthesia, and because it is a part of. I need to make sure that this thing I learn. But huh. So if nobody opts for it, eventually the university will close down that course and not teach anybody. So that is why
That will be even worse.
that will be a tragedy. Already in our entire nation, there are 2 universities which offer this course, and nobody's opting for them.
But I think that's more because not to offend anyone, but surgery seems to be hyped more than anesthesia.
Surgery is glamorous. Even I wanted to be a surgeon when I was in third year. I decided मैं surgery कर रहा हूँ. I like surgery, and it's very interesting and it's glamorous. You see surgeons perform amazing
Maybe because the
procedures.
recovery that you see in that, no?
Yeah.
From what problem you had, you solved the
Yes.
problem.
But then once I decided I want to get into anesthesia, I had made up my mind. I did not want to do surgery anymore. And in my fourth year, after the first half of my fourth year, I decided I'm going to get into anesthesia.
But somewhere, don't you feel that anesthesia has been made to seem a little scary also sometimes, and so people are
scary because people are not aware, or there is
of its safety?
Yes,
that you are the safety.
There you should be confident when you perform anesthesia, and that comes only when you have enough knowledge that this what I'm doing is not going to cause any problem, or even if there is a problem, I can solve it. That is where, and people have made it so seem so easy in a few cases rather than scary, that हमारा तो assistant ही देख लेता है anesthesia, हमें कुछ करने की ज़रूरत नहीं पड़ती. That is very unfortunate because if something happens, nobody is going to come after the assistant. They will be blaming you because you are the doctor. Nobody was imagining an assistant to take care of this important life and death
They trusted
thing.
you.
Exactly. So, if you're scared, then you should study and get more acquainted with the drugs what are available, and if you are not confident, then you can practice at one of the local clinics you go to, learn from them, and I'm sure every clinic has a specific protocol of drugs what they use for anesthesia, because it has worked well for them and nothing has gone wrong. Majority of the cases
They are
they are
comfortable.
comfortable with that and safe for them. So learn from those clinics. Then when you study further, you know that these are the drugs which could have been used. There are far more versatile drugs which are available now than just Sequel Thio, which was a standard in the university. Having someone to teach you is important as well. I could not have done these many surgeries if I did not have a good mentor. Because that having a good mentor gives you a good amount of confidence, and to someone to fall back on ki I'm facing this problem, what I can do about it,
Yeah.
and they can help you out.
Yeah. So two last questions for you. First is, in this specialty clinic that you've joined, what was the difference from other clinic practices and this practice? Is there any major difference in these practices? Since the specialty clinics are more of referral cases
Right.
that come, say, from someone like me, I can't do a procedure and I know that there are specialists, I will obviously refer it to you, them,
Right.
and ask them to do it. I know the patient is safer there than me trying to risk it.
Right.
So, is there any difference in a smaller practice or in a hospital as compared to what it is in a specialty practice?
General practices, you get all sorts of patients, right from simple, say, skin issue to limping or vomiting, diarrhea. At specialty hospitals, you get you the patients already have some rough diagnosis with them,
Yeah.
or the issue is narrowed down to what all is needs to be done next. The client is prepared in their mind, saying ki, we if we say that this patient needs a CT scan, they are quite prepared for it because the diagnosis more or less is already done. On If the patient has undergone an ultrasound and found a tumor on the liver, next we know is perform CT scan and find out where all it is attached. For that, the patient has to undergo anesthesia. So that kind of makes it easy. The communication is quite specific, that this is the problem, these are the steps we have to take next.
Don't you end up having more complicated cases in a specialty practice as compared to?
Yes, on a regular basis rather than a general practice where we see complications once in a while, once in 10 or 15 days. But here, every patient has some or the other complications. Uh, in cancer vet, almost all patients are on the geriatric side.
Yeah.
Almost all, but
all.
we do see young patients as well over there. For IVET, it's
Different complications of the eye.
just the eye. And can't imagine, we have so many patients in the city who had this condition, and we don't see as many cases in general practice.
Yeah. We don't.
We don't. That is why the concentration of your patients happens at one place, and it is what you see every day.
Yeah.
That is different. Exotic vet में तो there I just did, I sedated an albino rat to to remove a tumor from the extra thoracic region on the side. So that is not something which I had in my mind that I would be doing. I would be anesthetizing a rat.
The subject is fun.
The subject is a lot of fun and interesting. Unfortunately, there are not many people who get into this practice, and I want more people to learn anesthesia. It's very fascinating, very interesting. It is a little scary initially, but once you get that confidence, you can do everything by yourself.
Well. The last question I have for you is that when I discussed this podcast with you, and we both had one common, I think our common ground was that we wanted to do this for vet students and vets, and not for pet parents, so that we can go more in detail and give our vets more information than give our pet parents anymore. There's a lot of people doing things for pet parents, but very few informations that students or vets are getting. You're also writing a blog for anesthesia and more details about how they can learn or practice anesthesia in their own practices or when they're learning under someone. What is it about teaching that attracted you and that made you agree to coming here to teach us?
So I got interested in teaching when I was studying anesthesia. There, I had a bad. I My professor would tell me to conduct a small batch of veterinary students, tell them about basics about of anesthesia. And that is when I realized there is not enough information which we are given during our undergraduation, during our UG. So uh, even they got interested in learning or asking more questions. They were quite curious, the students in Kerala, to learn more about anesthesia. That is when I realized that there is a lack of awareness, uh, and we are not taught this subject very well as surgery or medicine or gynecology are taught in terms of clinical
Yeah.
subjects. Now I consider anesthesia to be one of those major clinical subjects which is very underrated.
Yeah.
And हमको सिखाया है कितना यार, a couple of pages in संधु in pharmacology, and surgery में थोड़ा बहुत regional blocks and general anesthesia का. But Lumb and Jones is this thick a book, and it has everything about anesthesiology which you should know, but you can read up at last minute as well. So that is how I got interested. And once I started practicing, there were other vets I got to know. And when I was at Happy Tails, I could tell them more about anesthesia, the surgeons more about anesthesia, and even they were fascinated. Ki, oh, this is something new which we got to know because of that. That's how I decided to write a blog. I'm not consistent at all. When I get time, I write a little, and I do conduct impromptu classes for vets, my juniors, and veterinary students as well. But it's the reach of making them aware is more through the blog because people can read it. Rather than reading, anesthesia is more of a practical subject which you have to get your hands on. You can't imagine what the drug is going to do unless you use it by yourself. So just theory does not help. It has to be done practically. It has to be done under controlled environment where somebody can tell you that these are the things you could have done differently. These are the mistakes you've made, and this is something which you can do. You alternatively, this is something which you can do. Again, same thing that not many people practice only anesthesia. You have surgeons who deal with that, and kind of frustrating for them as well. If you're genuinely interested, people would like to continue just doing anesthesia, but surgeons ka bhi hota hai ki I want to perform this surgery, so you do anesthesia like that. But making people more aware is something I aim at, and making the patient's experience safe uh, by making minimal errors from our side. And
If
that
it's
is-
okay with you, if any of our students want to ask further questions, is there any way that they can contact you on your email, or anywhere that they can maybe drop a comment on the video and you'll be able to respond to those?
Sure, you can take down my email, and yes, if there are any questions, happy to answer.
These classes that you conduct, are there a selective people that you do it for, or is anyone
So it's
okay
not
to come?
really a class as such. It is just कि सब free है तो चलो, I can tell you about these things. But if it is a structured pattern, like a uh, proper college curriculum, then it is faster to learn
Better.
because you have a timeline. You can't be like आज एक class ले लिया, I
Lazy
can do
about
it
it.
next week or 2 weeks later. We'll have some other discussion. If it is a proper structure, how postgrad or postgrad diploma is, then the learning is faster.
Yeah.
And so I've since our childhood, since our school, we've learnt everything in a timeline.
Yeah.
कि हमने first to 10th कर लिया, फिर junior college, then postgrad, undergrad, and then postgrad. But learning impromptu is not something which I would encourage. Unfortunately, we don't have a structure right now, but the universities which offer the degree and diploma courses, people should opt for it. If you don't want to go there, we can have a course like thing
Setup.
set up for that.
Okay. I will be putting the details of your blog and your email ID in the description,
Yes, thank
so
you.
people can read your blogs, and maybe if they have a question, they can email you,
Of course.
and they can have a further conversation with you. In
Yes.
case there are enough number of interesting questions in our description, in our comment section, would you agree to come back and answer those questions?
Definitely, we should have this discussion again.
Thank you and stay tuned for our next video.